In this lecture, we're going to talk about how your body defends itself against abnormal cells and pathogens or tissue damage. So we're going to talk about just general body defenses, and then we'll talk about specific body defenses, which involves immunology. So whenever you talk about immunology or body defenses, this involves your lymphatic system. Now your lymphatic system has kind of two jobs. Remember from your blood vessel lecture, we learned that the lymphatic system returns leaked fluid from the blood back to the blood. Okay, so that your fluid that leaks out in the capillaries will be returned back to the venous system so that you don't lose your blood volume and you can maintain your blood pressure. The other function of the lymphatic system is it's a cluster of, or it's a group of organs or tissues that house or facilitate the maturation of your lymphocytes. Now remember from your blood lecture we learned that there's two types of lymphocytes, B cells and T cells. And lymphocytes are white blood cells that play a role in fighting off infections. So the lymphocytes are housed in these lymph tissues. And as blood or lymph move through these tissues, the lymphocytes can detect any abnormalities. So they cleanse the lymph of pathogens. You have your lymph nodes, which are organs that are placed sporadically throughout the body, and they're connected to each other by lymph vessels. And as lymph moves through the vessels, it goes through the lymph nodes where you have a number of T cells and B cells there cleansing the lymph of any pathogens. You also have lymph tissue wherever pathogens may enter the body. So one way pathogens can enter the body is through the nose and mouth because that's open to the exterior. So you have your tonsils, which are found around the pharynx, and they can trap any pathogens that try to come in through the air or through your food. Remember from anatomy, wherever you have a mucous membranes line cavities that open to the exterior. So you have lymph tissue along these mucous membranes. So you'll find it along your digestive tract, specifically in the small intestines where you're absorbing things across the wall that may come from the exterior and enter into your blood. And so those are specifically called gut-associated lymph tissue, or we call them Peyer's patches. You also have a lot of mucus-associated lymph tissue, for example, in the urinary system because it opens to the exterior, female's reproductive tract, respiratory tract. Now the spleen is also a lymph organ because its job is as blood moves through the spleen, you have a lot of B cells there that are going to cleanse the blood of pathogens. The thymus, which sits over the heart, is a lymph organ, also an endocrine organ because it does produce hormones, but it's a lymph organ because that is where T lymphocytes mature, and we'll talk about that in this lecture. And then the bone marrow, because bone marrow is where you produce your lymphocytes, and it's where your B cells mature. Now the purpose of your body defenses is to either eliminate any abnormal cells, such as cancer cells or damaged cells, and also to remove any foreign material from your body. So we say foreign material are things that are not self, not your own. So your body needs to defend against invading pathogens. Pathogens are anything that can cause disease. So you have your viruses or bacteria or other things such as some protozoans can cause infection or parasites. The other thing is some cells get damaged and those cells need to be removed, and that's a role of body defenses. It breaks down worn out cells or damaged tissue. It also identifies and destroys any abnormal or cancerous cells. It also will reject any foreign tissue. So this plays a role in organ transplants. It can cause a problem because your body will reject anything that's foreign to it. So if you get a blood transfusion with a type of blood that isn't the same as yours, it's considered foreign. Or if you get an organ transplant, your body will reject it. So a lot of times people that do get organ transplants, they have to be on immunosuppressant drugs that actually suppress the body defense mechanisms. And sometimes your body defense mechanisms can work a little too well, or they can overreact or act inappropriately when they shouldn't. And that can lead to things like allergies or autoimmune diseases, which we'll talk about at the end of this lecture. So we say the body has two defense systems. They differ in their timing and how specific they are. However, they somewhat overlap, so they interact with each other and they kind of depend on each other. We can talk about how they work separately, but realize that they very rarely work separately and they usually work together. So those two defense systems are your innate immunity, and it's called innate because this is defenses that you're born with. And then there's what we call the adaptive or the acquired immunity. And it's acquired because you build this immunity as you are exposed to different things. So innate immunity is defenses you're born with, and acquired immunity you build as you age. So let's first talk about innate or your nonspecific system. This is quick to respond. It's your body's first line of defense against pathogens. So basically, your first line of defense is physical barriers. So your skin actually plays a role in keeping things out. Some people whose skin has been compromised in any way, whether it's a cut or, for example, burn victims where their skin has been compromised, they can get infections really easily. Or if you get a cut, it can get infected because it's actually providing a route for pathogens to get into your system. Also, your mucous membranes, for example, in your respiratory tract, mucus will trap dust, pathogens, and different things trying to enter your system. So the mucosa prevents entry of microorganisms. The second line of defense is if pathogens get through those first physical barriers and they enter into your system, then you have to have your second line of defense. And these are things like antimicrobial proteins that your body makes, phagocytes, which are cells that engulf other cells, and then there's other cells that we'll talk about. That's pretty general, but we'll talk about them in more specific. So the purpose of your second line of defense is to inhibit the spread of invaders throughout the body. So these things try to get at them as soon as they enter the system. And they trigger a localized response. So they try to stop that pathogen or microorganism from getting past that local spot and spreading throughout the body. And inflammation is its hallmark. Basically, inflammation is the process of your second line of defense. So let's kind of talk about what happens if a pathogen gets past a first line of defense and it gets into your system. Well, the first thing is a neutrophil or a macrophage will find the pathogen and it will engulf it by phagocytosis. So it will engulf the pathogen, or it could just be an antigen, something that's foreign, into the cell, and it destroys it. When the macrophage detects a foreign material, it will trigger what we call the inflammatory response. Really, what actually triggers the inflammatory response, I should say, is whenever a body tissue is injured. So you can physically injure it, like cut it and mechanical stress and damage it, or by infection. And the way infection causes tissue damage is a lot of the bacteria that infect the body, they release toxins that then damage the tissue. So you cause tissue damage either physically or by infection, and it will trigger the inflammatory response. The purpose of the inflammatory response is to prevent the spread of the agent to nearby tissues. Then you also need to dispose of any cellular debris, like cells that have been damaged by the agent, and destroy the pathogen that may be causing the damage. Then inflammation also puts into action the stages for repairing that tissue. So it needs to prevent the spread of the damaging agent, destroy the agent and any cells that have been damaged, and then help the tissue start to repair itself. So there's 4 cardinal signs of acute inflammation. I'm sure we've all had inflammation in our life, and you know that it's red. If you touch it, an area that's inflamed, it feels warm or it's hot. Sometimes you have swelling and you have pain. So these 4 cardinal signs are caused by increased blood flow to the area and also by chemicals that get released that can cause pain. So how does inflammation get triggered? Well, the first thing is, like I said, a phagocyte will detect a pathogen. And the way it usually detects a pathogen is phagocytes have receptors on their membranes called toll-like receptors, or some people just call them membrane receptors. And they recognize a foreign microbe, and they'll engulf it, okay? Because when the pathogen binds to the toll-like receptor, it triggers the phagocyte to engulf and destroy the pathogen and or release chemicals that will promote inflammation. Usually both happen. It will engulf and destroy the pathogen and release chemicals that trigger inflammation. Now the other thing that can happen is either the phagocyte directly detects the pathogen, as you see here, and it will destroy it, or sometimes what will happen is antibodies that will be released. They call them opsonins. That's a general term for something that triggers a phagocyte to engulf it. So 2 things that can trigger a phagocyte to engulf it. One is an antibody that binds to the pathogen, or complement proteins that bind to the pathogen. So we're going to talk more about complement proteins and antibodies. They basically mark the pathogen to be phagocytized. So the phagocyte engulfs the pathogen and then also releases chemicals that trigger inflammation. So these chemicals are released into the interstitial fluid by the injured tissue, a phagocyte, a lymphocyte, or a mast cell. And these inflammatory chemicals, there's tons of them, and you have a table in your textbook that lists even more than I have listed here. But some that you should be familiar with is there's kinines, histamine, prostaglandins, complement, and cytokines. These are all chemicals that can be released by these cells when they detect a foreign agent. Now, all of these trigger inflammation. We know that prostaglandins are released by damaged tissue. Complement are proteins that are just already in the body that get activated, and we'll talk about them. And then cytokines. Cytokine is a real general term for a chemical that's released by cells. But what these chemicals do is they cause the 4 signs of inflammation: redness, heat, swelling, and pain. Because what they do is they cause the local blood vessels to dilate. So when your blood vessels dilate, you increase the blood flow to the area, which causes the heat, and it also causes the redness. Okay, we call that hyperemia, which means increased blood flow. And then the capillaries also become leaky. They become more permeable. So that causes fluid to leak from the blood into the tissue. And that's what causes the edema or the swelling. And the edema causes the pain. The other thing that could cause pain is toxins that, for example, bacteria are releasing. But a lot of times if you can reduce the swelling, you can limit the pain when you have inflammation. And the purpose of increased blood flow and the capillaries becoming leaky is it increases the amount of blood cells that will come to the area to help fight the infection. Some of these chemicals also attract the white blood cells to the area. We call it chemotaxis, when cells are attracted by chemicals to an area. So how do you attract these white blood cells to the area? Well, we know that white blood cells, or your leukocytes, travel in the blood, and they need to move from the blood into the tissues if there's an infection. Neutrophils, we talked about, are the first on the scene. And when there's an infection, additional neutrophils are released from the bone marrow in response to chemicals that are released by injured cells. So cells get injured either physically or by pathogens, and those injured cells release what we call leukocytosis inducing factors, and that causes your bone marrow to produce more neutrophils. Actually, I'm going to move to the next picture just because this shows the steps, and you can read those steps in your outline. We have neutrophils are traveling through the blood. Now, in areas, let's say, where you have inflammation, let's say you have a nail puncture the skin, so you've compromised your first line of defense, and now you're on to your second line of defense. And let's say you had some bacteria that came in on that nail, and those bacteria are releasing chemicals and causing inflammation in that area, okay, because the cells are getting damaged. Those chemicals are acting as what we call chemotaxis, which attracts white blood cells to the area. The neutrophils are traveling through the blood, and they detect those chemicals, which cause the neutrophils to become somewhat sticky. They basically express what we call CAMs, cell adhesion molecules on the cell surface that allow them to stick to the blood vessel wall in the area where there's chemotaxis, margination, and then there's diapedesis, which is where the white blood cell actually moves like a little amoeba out of the blood vessel and into the tissue. And it will travel to the area where there's inflammation. So you have marginization, which is the neutrophils cling to the wall of the capillary where the tissue is injured. Diapedesis, which is where the neutrophil squeezes through the capillary wall. And then chemotaxis is the chemicals attracting the neutrophil to the injury site. And then the neutrophil can begin phagocytosis, engulfing any pathogens or damaged cells. So this is a little summary of what happens with inflammation. You have tissue injury, which causes the release of a number of chemicals: histamine, complement, kinines, prostaglandins. Now these chemicals cause vasodilation and increase permeability, and they can also attract white blood cells to the area. And the increased permeability causes more fluid, which causes your edema and your swelling and your pain. And vasodilation causes increased blood flow, which is your heat and your redness. So this increases nutrients to the area, and the temperature increases, which increases metabolic rate of cells. And this is all helping with the healing process. Now, pain and swelling is believed to happen because it temporarily limits your movement of that area, and that's supposed to help with the healing. And then we talked about that when the tissue is injured, it also releases leukocytosis inducing factor, which increases the number of white blood cells in the bloodstream, and they can move out to the area and start clearing debris and phagocytizing pathogens. Now, some other chemicals that can be released independent of inflammation is pyrogens. Pyro means fire, right? So macrophages can release pyrogens that travel to the hypothalamus and elevate the body's set temperature. And if you elevate the body's set temperature, you can run a fever. And this is a protective mechanism. Sometimes we think fevers as bad, and they can be dangerous if they get too high. What a fever does is they've seen that it causes the liver and spleen to actually sequester iron and zinc from the blood and store it, and basically it takes it away from the microorganisms, because microorganisms need zinc to divide, especially bacteria, and so it limits their growth. And the other thing is a temperature increases the rate of chemical reactions, which will speed up tissue repair. So a slightly high temperature helps limit the growth of microorganisms and helps you fight the infection. Then there's some other proteins that get released, and these are called antimicrobial proteins. And the purpose of them is they either attack the microorganism directly or they hinder the microorganism's ability to reproduce. So we're going to talk about two antimicrobial proteins. There's what is called interferon, which plays a role in viruses, and then there's complement proteins, which we mentioned, which tend to play a role with bacterial infections. So let's look at interferon first. Okay, so this is a general mechanism that helps protect cells from viral infections. So what happens is viruses are different than bacteria because in order for a virus to divide, he has to infect a cell and use your cell's machinery to make new viruses. Bacteria, on the other hand, they're prokaryotes and they can just divide outside of cells on their own. So what happens with a virus is a virus enters your body and he's going to infect a cell. And he injects his nucleic acid, either DNA and RNA, which gets incorporated into your cell's DNA. And when the viral gene gets inserted into the DNA, that virus is going to, or your cell will then make the proteins to make more viruses. And that's how cells or viruses reproduce. Now what happens with interferon is when a cell gets infected by a virus, it turns on a gene in that cell to make a chemical called interferon. So an infected cell will make interferon, which gets released by the infected cell. And interferon will go and bind to a receptor on a nearby cell that hasn't been infected by the virus yet. See the idea of I'm a cell and I get infected by a virus. And it's too bad for me because most likely I'm not going to survive because I have a virus in me. But I want to warn other cells that there's a virus nearby and maybe they can protect themselves before it's too late. So I release a chemical to tell them there's a virus here. So I release interferon to all the nearby cells. And when they get the message of the interferon that there's a virus around, they can take steps to protect themselves so that they don't get infected by the virus. So interferon gets released by a cell that's been infected by a virus. It travels to nearby cells and binds to receptors, and it tells the cell to produce an antiviral protein. PKR is an example of the gene that produces the PKR protein, which is an antiviral protein. And what that allows is if the virus comes and tries to infect the cell, it blocks the viral reproduction. Okay, so that cell is protected from the virus. So interferon is very, very interesting because it allows cells to protect themselves from viral infection. They've also seen that interferon slows the division of tumor cells, and so they've looked at using it, purifying interferon, and using it as a cancer treatment. The other thing it does is it enhances cells called natural killer cells, which will destroy infected cells. So natural killer cells, what they do is they actually go and lyse and kill any cancer or virus infected cell when they are exposed to them. Now we say that this is an immediate and nonspecific response. What I mean by nonspecific is natural killer cells can't determine what type of virus the cell is infected by. That's not what triggers them. What triggers them is just general markers that viral infected cells present on their surface, and they'll just go and destroy them. So we say that they're immunosurveillance. They just travel through the body and look for anything abnormal, and if they find anything abnormal, they'll destroy them. One thing to point out is viruses and cancer cells, you would consider them an intracellular agent because viruses get into the cell and infect them. And cancer, even though it's your own body, it's not a pathogen attacking your cell, but it's causing your cell to become dangerous and abnormal. So cancer cells and virus cells usually are destroyed the same way as intracellular pathogens. That's different than extracellular pathogens like a bacteria, which is outside of the cell. Now let's look at complement, which is another type of antimicrobial protein your body produces. Now complement, it's about 25 proteins that circulate in the body, and they're inactive if there's no infection. So they're inactive. They get activated if they are exposed to a carbohydrate chain that is found on microorganisms. Okay, so a lot of bacteria, for example, have certain sugar chains on their surface that your body recognizes as foreign, and those carbohydrate chains can activate the complement. And they work as like a cascade where you activate one, which activates the next and the next until all 25 are activated. The other thing that can activate them is if your immune system detects the microorganism and produces an antibody against it, the antibody can activate the complement. So basically, they're inactive until there's an infection, and then they get activated and they form what we call MACs, or membrane attacking complexes. And they insert themselves into the cell, let's say a bacterial cell or an infected cell, forming these little pores, okay, or holes. And basically, when they form holes, water will move into the cell and cause the cell to swell and lyse or rupture and destroy it. You have your cell, right? This is your cell. Now, there's kind of two different types of pathogens. You can have intracellular pathogens, which are viruses because they get into the cell. Now, the challenge to your immune system is it has to be able to recognize that the virus is in that cell because it's your own cell, so it doesn't look foreign to your immune system. So they require a certain type of immune response, which is slightly different than if you just have a bacteria cell that's outside of your own cell, because your immune system is able to easily recognize that as foreign. It's a little more challenging to recognize a virus or a cancer cell because it's your own cell that's infected. It doesn't look foreign. Okay, so we'll talk a little bit about how you deal with these intracellular pathogens. Your immune system has to recognize them differently than it has to recognize these extracellular pathogens like bacteria that are outside of your cells. So that's what I mean when I say they can produce pores in your own cells that have been infected by a virus and cause them to rupture, or they can form pores into the bacterial cell's membrane and cause the bacteria to rupture. Now, complement can also act as what we call opsonins, which, remember, I mentioned opsonins means that they mark bacteria for destruction by a phagocyte. So maybe he either produces MACs that cause the cell to rupture, or they could be proteins that just bind to the surface here and mark that bacteria for a phagocyte to come and destroy it. Or they can work as chemotaxins. Do you remember what chemotaxins do? Chemotaxins attract other white blood cells to the area. So all those things are what we call innate, which means you're born with those. Okay? You're born with complement and you're born genetically producing those complement proteins that will be activated when a bacteria enters your body. What you aren't born with is what we call your adaptive or acquired immune system, which is a specific defense system. And it's your third line of defense. And it will mount an attack against a particular foreign substance, so a specific type of bacteria or a specific type of virus. Now, it takes longer to react than your innate system. So a lot of times your innate system is the first thing that gets triggered, and then the adaptive response will get kicked in. It targets invaders that the body has previously been exposed to. And the cells that are involved here are your lymphocytes. So in your innate immune system, it's other white blood cells like your neutrophils, eosinophils, basophils that act as phagocytes, monocytes. And in your adaptive immune system, it is your lymphocytes, your T and your B cells. Okay. Now these two systems work together, but they're slightly different. Now your adaptive immune system is what we call antigen specific. What that means is it requires the production of specific lymphocytes and antibodies against a specific antigen. So let's define antigen. Antigen is any substance capable of provoking an immune response. It's anything that can enter your body and trigger an immune response or be seen as foreign. Okay. So any foreign protein, so any organism other than yourself, like a bacteria or a protist or a parasite that enters your body, he will have proteins on him that your body's not used to seeing, okay, because they're not found on your cells. So you can see that as foreign. Some of the nucleic acids that these organisms have will be considered foreign. Lipids in their cell membrane, or even polysaccharide chains on their cell membrane, carbohydrates. Your body is not used to seeing them on your cells, so they see it as foreign. Even other human cells that aren't yours, your body will see as foreign because you have your own unique protein markers on your cell surfaces, and they're different than protein markers on somebody else's. So that's what an antigen is. It's either a protein, a nucleic acid, a lipid, or a carbohydrate found either on a cell surface or just pieces of it. The adaptive immune system will produce a lymphocyte, a T cell, or a B cell that is specific to that antigen or an antibody. Its response is systematic. Now remember back when I said innate and we talked about inflammation, that's a localized response. If you have a wound and you have inflammation in that area, just that area is getting inflamed. So it stays localized. The adaptive immune system is systemic, which means that these lymphocytes and these antibodies that are going to fight off these antigens are circulating throughout your system. The other thing that's unique about the adaptive immune system versus the innate is the adaptive immune system has a memory. So what that means is the second time that you encounter that same antigen, your body's going to respond to it more vigorously and quicker. We can talk about two different branches of the adaptive immunity or acquired immunity. But again, these even overlap. So there's what is called the humoral, or I tend to call it the antibody-mediated immunity. So this is going to involve antibodies. And then there's what we call your cell-mediated immunity. Now, your adaptive immunity requires lymphocytes, and we learned in blood lecture that lymphocytes originate in the red bone marrow. Now, each lymphocyte is going to be equipped with two things. One is each lymphocyte has a unique receptor for a specific antigen. So you could kind of think of it this way. Every antigen has a different shape. Okay, whether it's a protein or lipid or carbohydrate, we learned that these organic molecules have a three-dimensional shape. So the antigen has a shape, and a lymphocyte has a unique receptor that binds that specific antigen. So it's not really this simple, but just so you get the idea, you could have a cell, a lymphocyte, that has receptors to just bind a lipid found in peanuts. And that's all he binds to. So he will circulate throughout your body for your whole life until he comes in contact with that peanut lipid. That person might have a peanut allergy. Or I have a lymphocyte that has a receptor that binds specifically to protein found on the viral surface of the chickenpox virus. So each lymphocyte is equipped with a specific receptor for that bacteria or for that virus or for a protein or a lipid or a carbohydrate found on that pathogen. And then it also has a receptor that allows it to distinguish its own cells, because something that's very important for lymphocytes to do, they have to be able to distinguish between self and non-self. So what belongs in your body, which is self, and what is foreign, which is non-self. Okay. So they have to be able to move around and say, okay, this is mine, this is not mine. When B and T cells are made in the bone marrow, they're not quite yet what we call immunocompetent. Immunocompetent means that the cell has the receptor and the ability to respond to the distinct antigen. So they're not born that way. They have to become immunocompetent, and they do so very quickly. But what's amazing is your T and B cells become immunocompetent. They get that unique receptor before they ever encounter the antigen that they later attack. So this is what is absolutely amazing about your immune system. You pretty much have a lymphocyte that will detect any foreign pathogen. Even though he's never seen the foreign pathogen before, you've made a lymphocyte that will recognize it in preparation, or it might enter your body someday. Once they become immunocompetent, once they get the receptor for that distinct antigen, they then get sent out to what we call secondary lymph tissues. So they'll get sent out to, say, a tonsil or a lymph node, and they'll sit there and wait to see if they'll ever encounter that antigen. Now, lymphocytes can travel throughout the body, but just imagine they go to that lymphocyte, they sit there, they have a receptor to detect one thing. Let's say I was designed to detect the chickenpox virus, and I will sit there until someday I run into it, and then I get to fulfill my dream of destroying the chicken virus. Now, once they actually bind the antigen, they come into contact with it, we say they mature into a fully functioning antigen activating cell, and they'll get to carry out their response. So B lymphocytes, they become immunocompetent. They get their ability to initiate an immune response in the bone marrow. So they get made in the bone marrow and they become immunocompetent in the bone marrow. Now B lymphocytes are responsible for the antibody-mediated immunity. So they're going to be responsible for the production of antibodies. Now antibodies are proteins that are made by B lymphocytes, and they travel in the blood and they bind to extracellular pathogens. So extracellular pathogens are things that are outside of your cells, such as bacteria usually is your most common extracellular pathogen. Now T lymphocytes, they become immunocompetent in the thymus. So this should be easy to remember. Remember B, bone marrow, T, thymus. Now T lymphocytes get made in the bone marrow, but then they travel to the thymus to become immunocompetent. Now T lymphocytes are responsible for the cell-mediated immunity. And cell-mediated immunity specializes in defending against intracellular pathogens, such as viruses that infect cells, and cancer. So this is just showing a picture. So your B cells and T cells, your lymphocytes, get made in the bone marrow, but they're immature because they're not immunocompetent yet. Now B cells will stay in the bone marrow to become immunocompetent. T cells will have to travel to the thymus to become immunocompetent. But we say they're still naive because they haven't found their antigen yet. They're just getting programmed for the antigen that they are going to search for. And then they'll travel to a secondary lymph tissue such as a lymph node, the spleen, a tonsil, a Peyer's patch in the intestines. They're going to sit there and see if they ever come into contact with the antigen that they were programmed to detect. Now, if they come into contact with the antigen, it activates them to initiate an immune response. T cells are very interesting. We're going to look at how they become immunocompetent. They have to undergo what we call negative and positive selection in the thymus. I call it T cell tryouts. Basically, your body makes a lot of T cells that have receptors for various antigens. And it's a real random process how you make the receptors. So your body could make a receptor that actually recognizes your own tissue. And you don't want that to happen because you don't want to initiate an immune response against your own tissue. So it's a very fine line that the T cells have to walk. They have to be able to recognize your tissue enough, but not too strongly to initiate an immune response. So they undergo tryouts. So there's negative selection, which will eliminate all T cells that are strongly anti-self. So if your body produces a T cell that has a receptor that binds to your own proteins or antigens too strongly, they need to get destroyed. So that's negative selection. And then there's positive selection, which selects for T cells that can somewhat recognize your own antigens, because you need to recognize your own, but mostly recognize things that are foreign. So what this kind of looks like is this is the selection process in the thymus. You have cells in the thymus that present antigens that your own cells carry in your body. And so if a T cell bind to it and recognize it weakly, then it will survive. If it can't recognize your self antigens at all, then it will be destroyed by apoptosis. And if it recognizes it too strongly, too vigorously, then it will die by apoptosis. So you need to have it somewhat recognize your own antigens. If it can't recognize it at all, it will be destroyed, or if it recognizes it too strongly, it will be destroyed. So now what we're going to do is we're going to look at the difference between the antibody-mediated response and the cell-mediated response. Now the antibody-mediated response is triggered by B cells. Now B cells have a specific receptor to bind a specific antigen. When they bind that antigen, it will trigger the B cells to multiply. And this is called clonal selection. Now most B cells will become what we call plasma cells when they divide. And they produce antibodies, which are proteins that will destroy that specific antigen that they recognize. And other B cells will become memory cells. They'll contain the receptor for that antigen, and they'll remain in the body so that they're ready to respond if you ever see that antigen again. So what this clonal selection looks like, imagine you have all these different B cells in your body that recognize different antigens. So let's say this guy that has green receptors recognize one antigen, this guy recognizes a different, and the blue one recognizes a different antigen. So you have this antigen that enters your body, that's foreign, and it happens to bind to this cell that has these purple receptors. So when the antigen binds to the cell that has a purple receptor, it triggers this B cell to proliferate or divide. And you're basically going to form a whole bunch of those B cells that have the same receptor for that antigen. You want to produce a bunch of cells that can produce antibodies to bind to this foreign antigen. You're basically producing an army, to destroy this antigen. This cell divides into more B cells that have the same receptor. And some of these cells will differentiate into what we call plasma cells. Now plasma cells produce antibodies. What an antibody is it's the same as the receptor, so it's the same three-dimensional shape so that it can bind that antigen, but they're not attached to cells. They're just proteins that get dumped into the blood, and now they can travel throughout the body to bind to that antigen if they find it. Some other of the cells will differentiate into memory cells, and these cells will stick around in the body for quite a long time, so that if you ever get exposed to that same antigen again, it will respond faster and it will produce a more vigorous response. This is what we call immunity. For example, let's go back to our chickenpox. Kids these days don't even have to have chickenpox because there's a vaccine, but we used to have to get chickenpox. So I think most of us probably had chickenpox as kids. You produced antibodies against chickenpox and some memory cells. So you did get sick the first time you were exposed. But then the next time you get exposed to the chickenpox, it doesn't mean that that virus isn't entering your body. It's just you don't feel the symptoms of the virus because your immune system initiates such a quick response you don't even feel sick. So what an antibody basically looks like is it's a protein. It's usually, we say it's Y-shaped. There's different types of antibodies. There's IgM, IgG, IgA, IgD, IgE. These are different immunoglobulins, which is another name for antibodies. And so they can vary in size. But an antibody basically has two important regions. It has a region called the heavy chain that's pretty much the same in all antibodies. And then there's a variable region that binds the antigen, and that's different for each type of antibody. So antigens can have different shapes. So this picture is showing you, okay, we have all these different shapes. And this antibody binds a specific antigen. So he fits this little red antigen. Okay, so he's specific. So let's look at the example of blood types. You know that you can only receive blood from certain blood types. Okay? And it all has to do with what type of antigens are on your red blood cells. If you are type O, you have no antigens on your red blood cell. We say your red blood cell is naked. If you are type A, you have antigens on your surface that look a certain way. In this example, they're showing the A antigen as these little round structures. If you're type B, your antigen looks different. Let's say it's this little blue triangle. And if you're type AB, the antigens on your surface, you have both. You have the A antigen and the B antigen. So the idea here is, if you're type AB, you have no antibodies, okay? Because you're not going to have an antibody against A or B because it doesn't look foreign to your body because you have those antigens on your cells. If you're type B, you have antibodies against A, okay? Because the idea is if you put A blood into someone that's type B, your immune system isn't used to seeing these little round antigens. He's used to seeing the blue triangles. So he would recognize this antigen as foreign and he would produce antibodies against it. If you're type A, you have antibodies against the B. And if you're type O, you have anti-A and B, because if you're O, your immune system is not used to seeing any antigens on the surface of your red blood cells. So, if you put type A or type B into your body, it will be seen as foreign. So we say AB blood is the universal recipient, because you can give someone with AB type B blood because he's used to seeing these blue markers because he has them on his surface and he has no antibodies against it. You can give him type A because he's used to seeing the little round antigens. And you can give anyone O because O has no markers on the surface, so he basically flies under the radar because there's nothing on his cell surface for them to recognize as foreign. Now, who can O receive blood from? Well, only type O, because if you put A in someone that's O, he has an antibody against it. It's foreign. If you put B in there, he has the antibody. So you kind of see how that happens? All cells have markers or antigens on the surface, and your body's used to seeing certain antigens. And if it sees a cell or any type of pathogen that has a different antigen on its surface than it's used to seeing, it's going to see it as foreign and produce antibodies against it. So what will antibodies do? How do antibodies, these little proteins circulating in the blood, fight an infection or destroy a foreign cell? Well, antibodies can inactivate the antigen in a number of ways. One way is it can trigger the complement. So if it triggers the complement proteins, remember your complement proteins will bind and lyse the cell. The other thing is it can do opsonization, or it can work as an opsonin. We talked about the opsonins are things that bind to a cell and mark it for phagocytosis. It can cause neutralization. Actually, I think I have a picture of these on the next page. Let's look at these as we go through them. It can trigger phagocytosis. So if I have this bacteria here and the antibodies bind to it, okay, which are these little blue Y's, it will mark it for a phagocyte to come and destroy it. Okay, so that's opsonization. It can trigger the complement system. So here's a little antibody that binds to a pathogen, and then it activates the complement proteins. And remember, the complement proteins will produce those membrane attacking complexes that cause the cell to lyse. The other thing antigens can do is what we call neutralization, because a lot of invading bacteria will produce toxins that can damage your cells. and you want to neutralize those toxins. So if the antibodies bind to those toxins can no longer damage the cells, so that's called neutralization. The other thing you can do is what we call agglutination, which is where they bind to the antigens on the cells and link the cells together. And so they form these large complexes that make it easier for macrophages to come and eat them. And then precipitation is kind of similar. It's the clumping of the antigens. So the difference between agglutination and precipitation is agglutination is the clumping of foreign cells. So this is what happens if you receive the wrong type of blood in a transfusion. All the foreign red blood cells will agglutinate or clump together. Or there's precipitation, which is just the antigen. For example, a toxin that's released by a bacteria will get clumped together. And the other thing is it can attract natural killer cells. Remember I told you natural killer cells will destroy infected cells. So the antibody-mediated response involves B cells that recognize the antigen and produce plasma cells that produce antibodies. Now the cell-mediated response mostly involves T cells. The cell-mediated response is designed to destroy intracellular pathogens for the most part. Now T cells can't necessarily recognize antigens without someone presenting it to them, like B cells can. So what happens is a macrophage will engulf an antigen and they destroy it, they chop it up, and then they display the foreign antigen on their cell surface. And when they do this, we now call them antigen presenting cells, or APCs, because they're presenting the antigen on their cell surface. They present that antigen to a T lymphocyte, usually a T helper cell. And that T helper cell has the specific receptor for that antigen. So the antigen gets presented by an antigen presenting cell to a type of T cell called a T helper cell. And it triggers the T helper cell to release chemicals that stimulate the division of various cells. So here's your antigen presenting cell engulfing the antigen and then presenting it to a T helper cell. The T helper cell releases chemicals that actually cause more T helper cells with the same receptor to be produced so that he can recognize the antigen. And then it also releases chemicals that activate what we call cytotoxic T cells. And these cytotoxic T cells specialize in killing cancer and virus-infected cells. And this is where your two overlap a little. The T helper cell also will go and activate more B cells to divide, so it enhances the antibody-mediated response. How cytotoxic T cells work. Remember, cytotoxic T cells specialize in intracellular pathogens. So a virus infects one of your cells. When a virus infects a cell, the cell will actually display the viral antigen on its cell surface. And that's how your immune system can determine that that cell is infected by a virus. So the cytotoxic T cell that gets activated by the helper cell will recognize that virus antigen and it will bind to it, and he'll release chemicals that then destroy that infected cell. So the type of chemicals that it releases, there's perforins, which basically kind of act like the MACs, or the membrane attacking proteins, but they basically are released by a killer cell or a cytotoxic T cell, and they poke holes again in that infected cell and cause the cell to rupture. There's also some other proteins that they can release called granzymes, which cause that infected cell to undergo apoptosis, which remember is programmed cell death. Alright, the next two slides, this slide and the next slide, are really good summaries of the antibody-mediated response and how you deal with extracellular pathogens. And the most common extracellular pathogen you have is a bacteria. And then the next slide shows how you deal with intracellular pathogens that get inside of your own cells, such as viruses and cancer cells. Even though cancer isn't a pathogen, it's your own cell that's gone haywire and needs to be destroyed. And it also shows how antibody-mediated and the cell-mediated somewhat overlap. So you have a bacteria that gets through your first line of defense, like the skin, and enters into the tissue, into the extracellular fluid. Now the bacterial antigen can do a few things. One is it can get ingested by a phagocyte, and the phagocyte can then go and present it to the T helper cell. And remember, the T helper cell can then release chemicals that activate B lymphocytes to divide. And B lymphocytes will become plasma cells and produce antibodies. So the B cell can be activated through the T helper cell, or the B cell itself can just detect the antigen on its own and start to produce antibodies. The other thing bacteria can do is it can activate, remember, the complement proteins, which then go and make membrane attacking complexes that destroy the bacteria. The complement proteins can also act as chemotaxins, which, remember, attract leukocytes to the area, which act as the phagocytes. The antibodies can also act as opsonins, which coat the bacteria and allow the phagocytes to engulf it. So you can see that all this is going on at the same time. So it's not like one thing happens, like the B lymphocyte recognizes the bacteria and produces antibodies. There's a ton of things happening. And what it's basically doing is you're trying to cover all your bases, that you have a ton of different ways of destroying one antigen. The B lymphocytes and the T lymphocytes, these are specific or adapted immunity. Remember, the complement and like the inflammation is just the innate. Now this is kind of looking at the cell-mediated response and how an intracellular pathogen would trigger an immune response. Let's say the virus gets into your body, but it's not into a cell yet. A macrophage can engulf that virus. It can present the viral antigen. And now he is a antigen presenting cell, right? Now when he engulfs the virus, he can produce chemicals that trigger inflammation, or he can produce, remember, the interferon that protects nearby cells. So now the virus can't infect him. These here, inflammation and interferon, are examples of innate or nonspecific immunity. Or he can trigger your adaptive response, which is this antigen presenting cell goes and he presents the antigen to a helper T cell. Now remember, helper T cells activate B cells and cytotoxic T cells. So the B cell can start to differentiate into a plasma cell and produce antibodies, and then it cycles, right? Because these antibodies can go back and bite into the virus and target them for macrophages to engulf them. And then T helper cell activates your cytotoxic T cell. The cytotoxic T cell proliferates, so you make a lot of cytotoxic T cells that can go and attack cells that have been infected by the virus and are presenting the viral antigen on the surface, and they'll destroy them by causing them to lyse by producing perforins, or cause them to undergo apoptosis by producing granzymes. Alright, so you have your antibody-mediated response, which is the production of antibodies, and we talked about how antibodies can mark the antigen for destruction. And then you have your cell-mediated response, which involves the helper T cells detecting antigens that are presented by an antigen-presenting cell, and the T helper cells activate the B lymphocytes and the cytotoxic T cells. The HIV virus that causes AIDS, it destroys these helper T cells. Okay, so it wipes them out. Now, if you wipe helper T cells out, you wipe out your cell-mediated response to where you can produce cytotoxic T cells that can recognize cells that have been infected. So what happens is now the HIV virus can infect cells and you don't have the cytotoxic T cells to fight the infection. Now you still can produce antibodies against the HIV virus and get the viruses that haven't yet infected the cells. However, you're also kind of making your antibody-mediated response less effective because T helper cells also play a role in activating B lymphocytes. So the HIV virus causes people's immune system to shut down by wiping out those helper T cells. So you have all experienced immunological memory, where you have immunity against a specific invader. So that means that you might get sick the first time you're exposed to the invader, but the next time you do not. The first time you're exposed to a specific antigen, it's your primary immune response. And you usually get sick the first time you're exposed because the cells take a while to differentiate and to divide. And we say there's a lag period about 3 to 6 days after your cells are challenged by the antigen until you start to initiate a pretty big response. And then your plasma antibodies don't peak in the blood until about 10 days. So it takes a while, almost 2 weeks to get the whole thing going. So you might get sick and feel symptoms. However, you produce memory cells that first time, and those memory cells will respond faster the next time you're exposed to that same antigen. So they can respond within hours, and you can have the antibodies peak at 10 to 3 days or 2 to 3 days, which is much faster than 10 days. So a lot of times you don't even feel sick because your response is so quick. So what this looks like is, let's say you get exposed to antigen X. It can take a few days until you even start producing antibodies. And they don't even peak into the blood until about day 10. And at this point, you're already feeling symptoms. But if you were exposed to it again, look at how rapid the response is. This is your y-axis is the antibody titer, which is the number of antibodies in your blood. So you produce a lot more antibodies very, very quickly the second time you're exposed. Okay, and that's basically considered immunity. You don't actually feel symptoms. Doesn't mean you're not exposed to it, you just don't get sick. But say now you're exposed to a different antigen, antigen Y, you start your primary response. So we say that this is an adaptive or acquired immunity. As you go through life, you get exposed to different antigens, and you start to build immunity against those antigens. So how do you build immunity? Well, one is you can have active immunity, which is where your immune system actually gets challenged and you have to produce antibodies against them. So your B cells encounter the antigen and you produce the antibodies. So you can acquire immunity actively, naturally, where you actually get sick by the bacteria or the virus and you produce antibodies. Or we can artificially acquire active immunity. And this is what we do with a vaccine. You actually inject yourself with either the dead virus or the dead pathogen, or it could be a virus or bacteria, because you're still exposing yourselves to the proteins or the markers on the surface of the cell, but the cell or the virus is dead. Or it's a weakened version of the virus or pathogen. So you put the antigen into your body, so you're still challenging your immune system, so it's called active, but you're acquiring it artificially. So viruses spare us the symptoms of disease, okay, because they're usually weak or dead antigens, okay, but it still provides our immune system with the challenge, and our immune system will produce the antibodies and build our immunity. Now, passive immunity is different from active because you're not actually challenging your B cells, okay, by the antigen. And so you don't get those memory cells. Basically, you're getting the antibodies from somewhere. So you're getting the antibodies. So you have the antibodies to protect you against the antigen, but your own immune system isn't challenged by the antigen. So you don't produce memory. So I just noticed an error, so let me just mention this now. Protection ends when the antibody naturally degrades in the body. You can get this passive immunity naturally. Biggest example of this is from the mother to her fetus, okay, via the placenta. So fetuses and infants do not have an immune system yet because they haven't been challenged. And it takes a while for their immune system to mature to be able to do this in life. The fetus can get protection because the antibodies from the mother that she has can cross the placenta. Or when infants are breastfed, the mother passes the IgA antibodies in her breast milk. So the baby has those antibodies to protect him against the antigens, but he's not actually producing his own antibodies. So as soon as those mother's antibodies are broken down, then the infant will no longer have the immunity until he acquires it himself. Or you can artificially acquire. You can actually get serum that contains the immunoglobulins. This is pretty rare, but you can. So this is just a summary of how you can get immunity. You can naturally acquire it actively by getting sick and producing antibodies, or passively, which is where you get the antibodies from a mother to an infant. Or you can artificially acquire immunity. Active, which means you're challenging your immune system by a vaccine, or passively, which is you're just getting the antibodies. So your immune system is usually pretty efficient at fighting off infections, but sometimes your immune system can overreact to antigens, or not react at all, and this can lead to immune disorders. Now, when your immune system overreacts to an antigen, we call that a hypersensitivity. Okay, so it's an abnormal, vigorous immune response, and it's usually responding to things that aren't necessarily life-threatening. So it's not actually a pathogen that it's responding to, it's just a different type of antigen, and this can cause your allergies and asthma. So some people overreact to pollen. Pollen isn't going to kill you, but it is an antigen that appears foreign to your immune system, and your immune system overreacts and causes some uncomfortable symptoms. We consider this an immediate hypersensitivity, which means it occurs within seconds to 20 minutes of being exposed to the antigen. So one type of immediate hypersensitivity is your allergies and asthma. Now what happens with allergies and asthma is your plasma cells produce a type of antibody called IgE to that antigen. Okay, so some people are predisposed to having allergies and asthma. It's 50% genetic, and so some people tend to produce IgE. Others might produce a different type of antibody like IgG to that antigen, which wouldn't necessarily cause allergy and asthma symptoms. So the IgE antibodies go and attach to mast cells. Now mast cells are filled with histamine. So the next time you are exposed to the same antigen, the antigen binds to the IgE, which are attached to the mast cells, and triggers the mast cells to dump histamine. Now histamine triggers inflammation and itching, and it's the inflammation that causes your symptoms of allergies, right? You have swelling, so you start producing more mucus. You have itching, you're itching your eyes, you're itching your skin, you're miserable. Your blood vessels become more permeable, which can cause your nose to run and cause pain. The other type of chemical that it can release is what we call leukotrienes, and these are specifically called slow reactive substances, and this can cause smooth muscle contraction in the airways, so it can cause you to feel like you can't breathe. So how you usually treat allergies and asthma is to block these two chemicals. You want to block the histamine using antihistamines, such as like Benadryl or Claritin. And then they now have drugs that block the slow reactive substances or the leukotrienes. You might have seen the commercials for Singulair. So that's blocking a different type of chemical. That's a newer treatment. We've had antihistamines for a long time. The drugs that block the leukotrienes are kind of a newer product. So what this looks like with allergies is you have the antigen enter your body and you have plasma cells produce antibodies against it. And in this case, they're tending to produce the IgE antibodies, which go and bind to mast cells. It sensitizes these mast cells. So the next time you're exposed to that same antigen, that antigen binds to the IgE antibodies on the mast cells and triggers them to dump histamine. Now, histamine will cause swelling and fluid to move out of the capillaries. It can cause more production of mucus, and then they can cause constriction of the airways. Those are your symptoms of allergies. Asthma is kind of also involved with this because you basically get mucus production in the airways, you get constriction of the airways, and asthma can be a chronic inflammation, okay, that can also cause the tissue to be damaged. Another type of hypersensitivity is what we call anaphylactic shock. Now this is unique because instead of, like with allergies, the antigens are usually localized in your respiratory system. Okay. Now with anaphylactic shock, the antigen enters your bloodstream. And if it enters your bloodstream, now you have an allergic reaction that's systemic. It's happening all over your body, and this can be life-threatening. So something like people that are allergic to bees, when you get the bee sting, the antigen enters into the blood. And you can go into anaphylactic shock. Or peanut allergies are like this because it's a lipid and it can enter into the bloodstream because it's lipid soluble and it can trigger anaphylactic shock. So the reason it's so dangerous is now you're not only locally releasing histamine and slow reactive substances like you do with asthma and allergies, but you are releasing it system-wide. So it can cause the constriction of the bronchioles, but it can also cause, if you have a dumping of histamine and SRSs all over the body, it can cause vasodilation in numerous blood vessels, and you can lose a lot of fluid from the bloodstream, which can cause hypertension. Basically, you're losing blood fluid, so you're having a drop in blood pressure, and that can lead to shock and death. So it's more life-threatening. And the way we treat anaphylactic shock is with epinephrine, because epinephrine will basically open up the airways to keep you able to breathe and also cause vasoconstriction. Alright, so those are two types of hypersensitivities that are usually immediate. And then there's what is called delayed hypersensitivities, which usually happen days later after being exposed to the antigen. So they're not immediate. And these involve your cytotoxic T cells. So an example of a delayed hypersensitivity would be poison ivy or poison oak. You can get the oil from the plant onto your skin, and it might be a day or two before you actually have symptoms. And what's happening here is it's triggering your cytotoxic T cells to overreact. And they start releasing all those chemicals like the perforins and the granulozymes that start destroying cells, and it can damage your own tissue. And so those can be treated with cortisone shots or corticosteroids, because remember from our endocrine chapter, you learned that cortisol will suppress the immune system. So you're basically trying to suppress your cytotoxic T cells from overreacting. Alright, so those are hypersensitivity, that your immune system overreacting. Then you can have the opposite effect where your immune system isn't reacting at all. And that's an immunodeficiency. So your immune system is lacking or it's not functioning. There's what's called SCIDs, or severe combined immunodeficiency disease. And these are people that have a deficiency of B and T cells. So they basically don't have a specific immune system. They may have their innate immune system, but not their specific. And these people, it's dangerous for them to even be outside because if they're exposed to any virus or any bacteria, even a fungus that's found in the soil, they can get sick and die. They don't have an immune system, so they have to live in a completely sterile environment. They are using gene therapy now to treat this disorder because they've identified the gene that is deficient that keeps your T cells and B cells from developing properly. And so what they've done is they've tried to replace that gene by using gene therapy in some patients, and so that their body will start to produce the B and T cells properly, and they've had some success. Another immunodeficiency is acquired immune deficiency syndrome, or AIDS, which is caused by the HIV virus, because the HIV virus destroys the T helper cells and it causes this syndrome. A third type of immune disorder is autoimmune diseases. And an autoimmune disease is when your immune system can no longer distinguish between self and non-self, and it basically starts to see your own tissue as foreign for some reason. And so the body will produce antibodies and cytotoxic T cells that start attacking its own tissue. And sometimes it attacks a specific type of tissue, like if it's your joint tissue, it could cause rheumatoid arthritis. Or multiple sclerosis is an example of an autoimmune disease that attacks the myelin sheath of the neurons. Okay, so it can attack different types of tissue. So what causes autoimmune diseases? Well, we're still not quite sure. There's some hypotheses, though, on what might trigger them. One is there could be inefficient lymphocyte programming. Remember I told you that the T cells have to undergo tryouts in the thymus? And if they recognize yourself too strongly, they're supposed to be destroyed and not enter into circulation. But sometimes that process might not happen properly, and a T lymphocyte that has a receptor for your own cells might get out and recognize your own tissue as foreign and trigger an immune response. The other thing that might happen is the appearance of new self-antigens later in life. Most of your T cells are programmed when you're younger. And so what will happen is, what if you have a mutation in a cell and your cell starts producing a new protein that it didn't produce before? And now that protein gets seen as foreign because your body hasn't seen it before. Another thing is, we've also found that a lot of times autoimmune diseases seem to be linked to viral or bacterial infections. And so what they think happens is you initiate a response to a bacterial infection, for example, and you produce antibodies against that foreign antigen. And later on, even after that infection is gone, those memory cells and the antibodies might still be there. And for example, those memory cells are traveling around your body and they're looking for the antigen. But what if they find a marker on your own cells that is close enough? It's similar to the antigen, and they might trigger an immune response to it. They've seen a link between a streptococcal infection, which is a type of bacteria, and the cause of rheumatic fever, which is an autoimmune response against the heart tissue. They do know that women tend to have autoimmune diseases 3 times more than males. And there is some really interesting new research out there about women who have, when they carry babies, some of the fetal cells can cross the placenta and enter into her bloodstream, and the immune system doesn't recognize them right away because they're called HLA markers, which are basically your own markers. Genetically might be similar enough to hers that they don't trigger a response right away, or they get by through the immune system for a while. They can implant in tissues and remain there and proliferate, and then later on the immune system starts to recognize them and destroy them. There's some really new, interesting research on that. It's fascinating. And the way they figured it out, that there's actually fetal cells from fetuses that mothers carry in her own system, is they found in women that carried male children, they put a marker in that would mark cells that have Y chromosomes, and they were finding cells in the mother that carried Y chromosomes. And that's what triggered all this research, is that's how they realized that some of those fetal cells actually remained in the mother's body for a while. So it's kind of interesting. I don't know too much about that because that's all kind of new, but they're looking at that for maybe why women tend to have autoimmune diseases more often than males.